Hello guys, today we are going to discuss rheumatology, in which our topic of discussion is rheumatoid arthritis. What is rheumatoid arthritis? It is a chronic systemic inflammatory disease characterized by symmetrical deforming peripheral polyarthritis. It is more common in females than in males. It occurs in 5th and 6th decade of life, and it is associated with HLA-DR4. Let's move on to its pathogenesis. What happens is it is basically due to genetic and environmental predisposition for rheumatoid arthritis, in which there is modification of IgG antibodies and modification of type 2 collagen and vimentin. These collagen and vimentin are citrulinated, that is, arginine peptide is replaced with citrulline peptide, called citrulinization. These citrulinated peptides are not recognized by our bodies, so these leads to obviously autoantibodies formation called anti-CCP. And those modified IgG also induce autoantibodies formation, which are IgM type, called rheumatoid factor. These antigens basically go to the synovial joints via circulation and causes complement fixation with their autoantibodies and activates the inflammatory reaction, in which macrophages causes angiogenesis, neutrophils recruitment, and fibroblast activation. The neutrophils causes release of reactive oxygen species and myeloperoxidase, which causes joint erosion, articular cartilage erosion, and inflammatory reaction causes granulation tissue formation. It causes synovial membrane thickening. This granulation tissue is called pannus. This swollen joint and granulation tissue consists of fibroblasts, myofibroblasts, and inflammatory cells. This pannus causes joint erosion, that is, bone and cartilage both are eroded. The activated synovial cells also release proteases, which also causes protein destruction of the joints. What is important to be noted here that there are clinical signs and symptoms in which there is ulnar deviation. We will discuss later. Okay, first of all, let's move on to other things first. Clinical features are there is symmetrical involvement of joints. What here it means is that if wrist joint of one hand is involved, the wrist joint of the other hand will also be involved. This is the basic thing that happens in rheumatoid arthritis, that is symmetrical involvement of joints, and these joints will be swollen and painful. It is also polyarticular, that is multiple joints will be involved at once, and usually small joints are involved, like proximal interphalangeal joints and metacarpophalangeal joints. This is very high yield that distal interphalangeal joints are never involved in rheumatoid arthritis. There is morning stiffness that lasts for around an hour and improves with activity. What happens is that the inflammatory conditions, the morning stiffness caused by inflammatory conditions last for around an hour, and those that is not caused by inflammatory conditions, that is non-inflammatory conditions like osteoarthritis, it will last for morning stiffness will last for around 30 minutes or less, not more than that. Here the other thing that is written here in morning stiffness is that it improves with activity. So what happens is that all the debris that is collected overnight in the inflamed joint due to inflammatory reactions will be cleared off with activity. causing improvement in his activity and movements and his condition. There are also constitutional symptoms. Obviously, it is inflammatory disease, so there will be fever, fatigue, anorexia, and weight loss. Signs: there is radial deviation of wrist and ulnar deviation of fingers. Here you can see that the wrist joint is deviated radially and proximal interphalangeal joints are deviated on the ulnar side. So the thing is that this deviation is because of the myofibroblasts which are present in the swollen joint and causes contraction of the joint, leading to deviation. Another thing is that there is cervical joints involvement, usually C1 and C2. Note, it is very high yield that lumbar spine or lower back is never involved in rheumatoid arthritis. And second thing to be noted is that whenever a patient is of rheumatoid arthritis is going to have a surgery for anything, and he has to be given anesthesia, or he has to be intubated, endotracheal intubation, then in both of these cases you should be doing cervical spine imaging to be certain that there is no involvement of cervical joints. Like in surgery cases, anesthesiologists should be informed about the condition that the patient is having rheumatoid arthritis, and there can be atlanto-occipital subluxation. So you should take this into consideration. Okay, there are certain extra-articular manifestations, like there is a keratoconjunctivitis, dry eyes, painless thinning of the sclera, and rheumatoid nodules in the skin. It is not usually present in all the patients, but it is there in some patients. So you should keep it in consideration. Okay, so syndromes associated with rheumatoid arthritis are Kaplan syndrome and Felice syndrome. Kaplan syndrome is basically rheumatoid arthritis and pneumoconiosis, which is a restrictive lung disease and lung nodules. Felice syndrome, in which there is rheumatoid arthritis, splenomegaly, neutropenia, and skin pigmentation. Diagnostic criteria. We have set a diagnostic criteria for rheumatoid arthritis accepted internationally, which says that at least 4 of the following features should be present at once to be established as the diagnosis of rheumatoid arthritis. For this, first of all, morning stiffness, which should be around the joints, which should be around at least an hour or 30 minutes or more than 30 minutes, and synovitis, which should involve 3 or more joints at once. And there is synovitis of hand joints like proximal interphalangeal joints, metacarpophalangeal joints, and wrist joints. Symmetrical joint swellings, this is very high yield, and rheumatoid factor and anti-CCP should be positive. ESR or CRP are raised, and duration of 6 weeks or greater. That is a patient complaining of these symptoms should be having these symptoms for 6 weeks or greater to diagnose as rheumatoid arthritis. Non-criteria. These were included previously, but now as these are not present in all the patients, these have been excluded, like rheumatoid nodules and periarticular osteopenia in hands and wrists. What happens, periarticular osteopenia, what happens is that due to lack of movement due to painful and swollen joint, the above joint are also affected. That is, they undergo osteopenia or osteoporosis due to lack of movement or lack of activity because of pain proximally. Investigations. You will do CBC, ESR, CRP, and a all will be raised. CBC will show anemia, ESR and CRP will be raised, ANA will be positive, RF positive, anti-CCP. It is the most specific test for rheumatoid arthritis. If they ask you what is the most specific test that will lead to certain to confirm diagnosis of rheumatoid arthritis, then you will say anti-CCP. And you will also do X-ray of hand and wrist. Management. We usually give DMARDs. Basically, DMARDs is the treatment, but what happens is that DMARDs are not effective in the first 3 months of their doses. So along with DMARDs, our best initial treatment is NSAIDs or corticosteroids to relieve the pain, but they are not good at stopping the progression of disease. DMARDs should be given with them. The best DMARD that is given is methotrexate. There is something like if there is no joint erosion, then we will prefer hydroxychloroquine, sulfasalazine and minocycline. Sulfasalazine is basically safe in pregnancy, and hydroxychloroquine has a side effect of visual problems. So whenever you are giving hydroxychloroquine, then you should examine your patient and every 6 and 12 months for his visual acuity and visual problems. And if there is joint erosion, then the best DMARDs that you can give him is methotrexate and leflunomide. Okay, there is another thing, that if you are giving a patient methotrexate, then you should not conclude that the methotrexate is ineffective unless you complete a course of 6 months. That is very important, that you should at least complete the 6-month duration. Then after that you can conclude that it is ineffective. And there is another thing, that you should always give folic acid when 5 grams per week. In rheumatoid arthritis, if you are giving methotrexate, because it has a side effect of pancytopenia and hypersegmented neutrophils, that is, it causes megaloblastic anemia because it inhibits the pathway of folic acid and RBC's further division because of folic acid. Thank you. This is all for now. I hope you have learned this.